Welcome to Reboot with Dr. Arasi Maran. I have a fantastic guest here for us today. I have Dr. Thomas Curran. Dr. Thomas Curran was originally from Philadelphia, and then he received his undergrad degree from Duke University and his medical degree from Icahn School of Medicine at Mount Sinai in New York. He completed his general surgery residency and his research fellowship at the Harvard-affiliated Beth Israel Medical Center in Boston. And at that time, he also received his master's in public health from Harvard T.H. Chan School of Public Health. He then pursued a year of specialty fellowship in colorectal surgery at the University of Minnesota, and then he joined the Medical University of South Carolina. He works on all things colorectal related, inflammatory bowel disease, and also colorectal cancer. Dr. Curran today is a very special guest because today I want to talk about colon cancer. The incidence of it is increasing. My own first degree relative had suffered with colon cancer, and I'm petrified of colon cancer in general. I thought, we would deep dive into this and kind of talk about how can we, detect this colon cancer early. And I know there's a lot of colon cancer awareness programs going around. So Tommy, welcome to Reboot, and thank you for joining and agreeing to do the show with me today. And, I'm going to give you this golden opportunity to brag about yourself. So tell me about you a little bit more beyond what I have given in the introduction as well.
Absolutely. Well, to start off, I can't thank you enough for this opportunity to have this conversation. I think it is a critically important one to get the message out there about colon and rectal cancer and how we can better prevent this disease, how we can treat it for those who are affected. A little bit more a sense of my own background. I've been at the Medical University of South Carolina for 6 years, and I am thrilled to be here. I work with a fantastic team of colon and rectal surgeons, gastroenterologists, radiologists, medical oncologists, radiation oncologists. And I bring this up because these truly are multidisciplinary disease processes everywhere, beginning with the primary care physicians on through the highly specialized type of doctors to help take care of colon and rectal cancer. From a clinical point of view, as you mentioned, I treat all manner of colorectal disease conditions, but really a specific attention to inflammatory bowel disease, a condition that includes Crohn's disease and ulcerative colitis. And importantly, these are a group of patients who are at increased risk of colon and rectal cancer. And so colorectal cancer is something that I treat day to day in my practice. From a kind of day-to-day clinical point of view, I do preventative strategies, things like colonoscopy, and we'll touch more on that a little later, I'm sure, and then surgery for treatment of colon and rectal cancer, among other things. I have an active research program that's funded by the National Institute of Health, the NIH, and the National Cancer Institute, and we're looking at strategies and ways to reduce the risk of blood clots after major cancer surgery. So that's something that we're really excited about, and it is also a major major issue that confronts these patients. But I mentioned that this truly kind of begins with kind of the primary care level and recognition of who are the patients who are at risk and who can benefit from testing to diagnose these things early or ideally prevent them. So I think the first thing to perhaps discuss is that colorectal cancer is quite common. It's the third most common cancer overall, affecting both men and women. And sadly, it's right at the top of the list as well, second or third in terms of the number of cancer-related deaths per year. So it is something that's quite serious. The lifetime incidence in the United States, so it tends to affect somewhere around maybe 1 out of 23 to 1 out of 25 patients over the course of a lifetime. So that's puts that in some type of context. And annually, we have about 150,000 new cases per year in the United States. From a epidemiology point of view, as we study who are the patients who are affected by this, there are some really outstanding successes, but also some areas where we have some reason for concern. Looking at this over a long time horizon, if we go back, say, 50, 60, 70 years, we know that in general, as a society, there were some habits that contributed to colon and rectal cancer, among other diseases. Things like smoking and drinking to excess, and some of the ways, kind of those behavioral type things. So historically, the incidence of colorectal cancer was quite high, and then the public health interventions related to this have had some successes. So as we've gone into the 80s, we saw that there began to be a decrease in this that we believe is probably related to addressing some of those high-risk behaviors like smoking and alcohol use.
So, Tommy, clearly this is a very common cancer, the third most common cancer. And, the numbers you're giving me are pretty staggering. Like 1 in 23 to 25 people have colon cancer. It's kind of scary, actually. I think just for the audience sake, can we go back a little bit to the basics of colon? Like, how is that? We know there's a food pipe, the esophagus, there's a stomach, there's a small intestine. Like when you're talking about colon cancer, are you talking about the entire large intestine? Can you kind of talk about a little bit of what is the job of the colon itself, and maybe why it is so much more common than maybe a small intestine cancer?
Yeah, those are really outstanding questions. And from an anatomy point of view, this is something that probably a lot of folks get a little squeamish of talking about because it has to do with, passing our bowel movements and things like this. So folks aren't so excited to talk about it, but it really is important. You hit most of the high points. So when we eat something, goes down into the esophagus, that connects the mouth to the stomach, digestion begins there, and then the food travels through the small intestine and goes to the large intestine. And this is a point of confusion for some people, that the colon and the large intestine, those are basically two names for the same organ. And then the rectum is really just a continuation of that same organ. It's roughly the last 6 inches or so of the large intestine. The colon is kind of shaped like a question mark. It starts on our right side in our abdomen, comes up, over, down, over to the left side and down to our pelvis. And then, of course, there's the exit at our anus. This has the last inch or two of the GI tract. So that's kind of the area that we're focusing on, the large intestine or colon and rectum.
And if I'm correct, the type of cancer you get in your colon is completely different from the type of cancer you can get around the anus.
Yes, that is actually a really important distinction because those cancers have slightly different risk factors and prevention strategies. The type of cells that live in the anal canal actually are close cousins or fairly similar to the cells that live in the cervix for female patients. Mm-hmm. And so and almost all of the cancers that develop in both the cervix or the anal canal, these are associated with a virus called the human papilloma virus, or HPV. So some people may have heard of this. It is the type of virus that can cause like a wart on your finger or even things like that. So most of the prevention strategies, many women are familiar with a pap smear. So there are similar prevention strategies for anal cancer in patients who are at high risk, which mainly are patients either who have a compromised immune system. So patients who have HIV, or some who have organ transplant, and then others who have behaviors that put them at higher risk. So mainly anoreceptive intercourse. So that's kind of the approach, or some of the considerations for anal cancer, whereas colon cancer is a different entity, a different kind of begins from different type of cells.
Again, like, is the incidence of colon cancer more because we are storing the stools in the colon? Is that why it is, so much more prone to cancer? Do we know that?
Yeah, it is a great question, and it's an area of really active investigation. So the short answer is kind of nobody knows the full story. We know that there are some patients, some people whose genetics predispose them to colon and rectal cancer, and this is something we're learning so much in even the last 5 to 10 years, and looking ahead to the future. I think this will be an area that helps us tremendously to understand who are at increased risk. So we think it's some degree of our genetics. We think it is some degree of things we're exposed to over the course of our lifetime, things we eat, certain things. I mentioned some behaviors like smoking, but focusing in on diet, and this is a hot topic right now, the microbiome, the type of bacteria that live in our bowels. We think that there may be some implication there as well, that there are certain types of foods or types of that can maybe give advantages to bacteria that could ultimately be harmful to us. So these are things that are being studied, but we don't have really the whole answer just yet.
So can we kind of put patients who get colon cancer into two buckets, those who are genetically predisposed and higher risk, and then the general population who just from behavioral and lifestyle habits are at high risk for colon cancer? Is that a
That's
correct
a
way
good
of
way
viewing?
to look at it. And historically, we've identified some type of genetic mutations that do put patients at increased risk, and this can be cancers that run in families, and some of the common ones that people may have heard of are something called Lynch syndrome, another called FAP, or familial adenomatous polyposis. These are kind of long names, but basically they are people that are at increased risk. And for those mutations that we're aware of, this is probably only a small minority of people who are getting colon and rectal cancer, maybe in the order of like 5 to 10%, with the remainder being people who don't have at least a genetic predisposition that we're aware of. And that's something that may change with time as we're testing more people's genetics, and learning more, that there may be some mutations that are more subtle, or have maybe just a slightly increased risk relative to these other mutations that increase risk pretty dramatically.
I'm surprised by that. So you are telling me the majority of this third most common cancer is coming from lifestyle behavior changes.
We think so, and it's really fascinating to look around the world and see that of course there are some genetic differences around the world. There are also differences in the way that we live as societies, things that we eat and drink, and just a lot of things that are variable depending on the place where someone is. And as an example of this, in the Far East, say in Japan or China, colon and rectal cancer is much less common, but stomach cancer is more common. And so in the same way that we have kind of screening tests and things for colorectal cancer, in Japan they do the same for cancer of the stomach. And so we don't 100% understand why that is, but we think that certainly the things we're exposed to over the course of our lifetime, they likely play a role.
Let's talk about the screening, because this being, as you said, the third most common cancer. And I know the screening parameters keep changing ever so frequently. Currently, at what age should we start thinking about screening for colon cancer, and what does it look like?
Sure. This is something that, as you said, this has kind of been a moving target. And as a healthcare field, we've been trying to keep up with and adjust to the things that we're observing. Looking back, the average screening risk age to start has been 50. But just within the last few years, this has moved down to 45. And this is in response to what we see on a kind of population level in the United States, in the UK, in Australia, New Zealand. All have seen this increase in colon and rectal cancer in younger people in the last 10 to 20 years. And again, we think that there may be some associations with it. Kind of mirrors the obesity epidemic, but that's not to say that all of the patients who are getting early onset colorectal cancer are obese. That is not the case, but it sort of tracks with that. So currently it's 45, but there are ways, and this is important, that this is for average risk people. So if you're having no symptoms, then 45 is the age to start screening. And these, who else is average risk? These are basically patients who have no one in their family who's had colon or rectal cancer, and they're having no symptoms. So that would be 45. For patients that have a family member who's had colon or rectal cancer, then they would very likely start screening earlier. So that can vary a little bit on the number of family members and how old the family members were when they were diagnosed. But in general, it would start at least 10 years earlier than the youngest diagnosed family member. So if someone had a family member diagnosed at 40, they would start screening at 30 to really be sure they can be looking out for this in a preventative, proactive way.
So, when you talk about screening at 45, that seems like, number one, a really young age. And that is, again, I don't think people are aware that you need to start, because 40s is thought of like this golden period where you're not old enough.
I hope so, as someone who's 44.
But the thing is, I think people are not aware that you have to think about screening for colon cancer at 45. And what would that screening involve? Because I do see TV ads for, home tests and things like that. Is this something, a test they can buy off the shelf? Is that good enough, or do they have to go to a doctor? Like, what is the screening test for a average risk 45-year-old person?
Yes. So for this, most professional societies advocate a kind of a menu of options. So these fall in a couple baskets. One of these are stool-based testing. So this is like you provide a stool sample, and that is analyzed in a way that can detect colon or rectal cancer. Another group of tests are endoscopic, meaning that they put a camera in your bottom and look, this is a colonoscopy. And then the last group are radiologic tests, so specialized CT scans and things that can try to look for growths in the colon or rectum. So with that, this menu of options that's recommended by major professional societies and things, this is something that, depending on which you choose, that can influence how frequently you need to do the testing. So, for example, with colonoscopy, if you have a negative colonoscopy, meaning no polyps or growths are found and you have no family history, then your next one would generally be 10 years later than the first one. With the stool-based testing, so the current kind of most advanced generation of this, many people have seen the Cologuard ads on television, and this looks for fragments of DNA that are found in cancers and polyps in the stool, and it can identify these DNA fragments at very low, this genetic material at very low levels. that's something that someone would have to do every 3 years. But if the test is positive, if it shows that there could be something going on, then that individual would have to get a colonoscopy to look and see what is, what may be there. If it sometimes it's nothing, sometimes it's something.
So, obviously, as a 48-year-old, I chose the Cologuard because it's easy, one and done. I can do it at home and I can do it every 3 years, etc. And I obviously had to look up and how accurate is this, or how believable if I get a negative Cologuard, how much can I believe it? So what do you think about the, negative predictive value, or if I don't have cancer, how sure can I be that I actually don't have cancer?
Yes. So for cancer, Cologuard is excellent. Has excellent negative and positive predictive value. So if someone gets or the sensitivity of Cologuard for cancer is in the kind of low to mid 90s, like 92 to 94%. So really good. Where it is less successful is in identifying advanced polyps. So these are kind of the type of growths that can become a cancer. And its sensitivity to detect those is maybe around 45%. So it's an outstanding screening test for colorectal cancer, but not quite as strong to identify some of those precancerous growths. And that's where colonoscopy has kind of the benefit of being able to find these precancerous growths and remove them to prevent that progression to cancer. And as to which test to advocate, I think all of them add value. So I think it depends whose hat you're wearing. Are you wearing the hat of an epidemiologist that we want to screen as many people in the population as possible? And that's where I think having this menu of options really shines, because there are people they're so busy as you are that doing the Cologuard, gets that test, gets you screened, and it's less disruptive to your life. Because doing a colonoscopy, you need to take a day off work, you need to have someone else with you, and there's a lot that goes into that. So I think if you're looking to reach the greatest number of people, it's really outstanding to have these different options, all of which have their pros and cons, but are very effective tests.
I honestly don't want to go too much into the treatment of colon cancer because, it depends on the stage and things like
Sure.
that. But instead, I want us to change direction, predisposing factor. You talked about the genetics things, but the lifestyle, there's, why is this increasing? What are we eating? I once had Raul Rosenthal as in the podcast. He's the obesity surgeon from Cleveland Clinic, and
Mm-hmm.
he truly believes that cancer is a metabolic disease, and the risk of cancer parallels the amount of obesity, or and the visceral obesity, etc. I would like you to comment on what your thoughts of why you think there's we have an uptick in colon cancer in all the developed countries. If you
Yeah, and with the caveat that no one knows for sure, I think that really would be the leading hypothesis. That our best understanding, if you're kind of looking at things in total, is that this has mirrored the increase in consumption of highly processed foods. We think that does contribute to inflammation in our system, and this is probably an area that gets close to what you deal with day to day, the inflammation in our blood vessels. I know very little about this, but that it can impact deposition of plaques and things within our blood vessels. And this is something that can influence the health of our gut. And I think that's probably the most compelling explanation right now, because it does really fit what we see when we look around the world at places that eat in the way that we eat. they are all seeing this, somewhat varying degrees, but this is an international phenomenon that we are seeing this. And this is an area where I think the genetics are interesting because we know that, for example, people do not need to necessarily be overtly obese or have to look at them. You may not say, oh, this person is very heavy or very obese, and yet they may have a lot of sort of fat in their midsection or things that contribute to this inflammatory environment that can kind of predispose to colon and rectal cancers as well as other health impairments.
So, how we do coronary calcium score to evaluate for blockages in the blood vessels. Is there any research on visceral obesity and thickness of visceral abdominal fat mass and colon cancer incidence or anything like that?
I think those are things on the horizon. So I think that, and this is an area where there is a lot out there, especially, if anyone goes to a health food store, I mean, there are aisles and rows of all these different things that are intended to improve people's gut health. But I think looking at things in broad terms, there are some pretty safe patterns of eating that folks could likely follow and be in good stead. So we know, for example, that a high fiber diet is excellent for our gut, and it's excellent for reducing levels of inflammation, is good for our cholesterol. And so having high fiber, and that tends to be consumption of lots of fruits and vegetables, whole grains, even natural-based fiber supplements, things like psyllium husk or chia seeds. They're all kind of ways to incorporate these things into your diet. But these fall into a category of prebiotics. So people are probiotics, and these are consuming the actual bacteria. But we know that the friendly bacteria, they love this fiber, and so that's something that is excellent to do. We know that in general, having moderate amounts of or kind of moderating the amounts of red meats and cured meats are probably useful. It's not to say you can never have a cheeseburger. I love a good cheeseburger, but it is something where this is something maybe you don't want to be eating that every day or having that as a very frequent part of your diet.
See, I think one of my biggest problems is that we as physicians or even in the public health world, we have not defined moderation adequately. Because we have not defined what is moderation, we are not able to give clear-cut guidelines, and people get confused because there are these bandwagons where, say no to red meat, it's going to cause colon cancer and heart attacks and strokes, and then there's this other bandwagon says, let's do the carnivore diet, and it's a much simpler diet, etc. And it's such a big divide, and I just feel like, and I try to tell my patients, you can have red meat once a week and that will not kill you. But if you have red meat 3 times a day, 7 days a week, and don't have any vegetables or berries or anything, that's not going to be good for you either. What are your thoughts? Like, what do you define as moderation?
This is really fascinating, especially in our current climate where public health has, I guess to be fair, has struggled. A lot of people skeptical of public health messaging. And this is an area where if you really get into the weeds, doing high quality science related to diet is very difficult. So a lot of the studies are based on huge population of people that fill out surveys, and it's like, how well does this person remember what they had for, I might struggle to tell you what I had for breakfast yesterday, but this is the basis of a lot of these studies. So I think that where you went with this is exactly where I land, that on either extreme, it's pretty easy to say this seems like it's not a good idea or you'd be well off to do this. it gets probably a bit gray in the middle. And I think being honest with people about that is important, because some of these things are not the certainty that, science is messy sometimes. And this is one where, for example, I drink coffee and every so often, or have a glass of red wine, that if I pick up the New York Times or Wall Street Journal or something, one week red wine is good for me, and then another week it's bad. So it's hard to know, but I think, as you said, having something, once or twice a week, I'm sure I would strongly suspect is fine. Having it, carnivore diet with a steak for breakfast, lunch, and dinner is probably way over the top.
See, I also feel like the crew in the carnivore bandwagon, they actually eat clean. All they are eating is meats, different types of meats, and they don't eat any sugar. They don't eat any seed oils. They don't eat the other inflammatory factors. So maybe, and they have eliminated. It's an elimination kind of a diet. So they
Mm-hmm.
probably have very less autoimmune disease or something. They have a very simplistic diet, but it's good quality. I mean, beef is a complete protein, and chicken is a complete protein, and salmon is going to have all your good healthy fats and stuff like that. So I struggle as a cardiologist also to say, I said, but as long as your plate is not filled with this ultra processed, reheated seed oil food, fried foods, and just use common sense. That's what I'm like. You cannot replace or you cannot substitute common sense, and I don't think we can also define everything as medical professionals, right?
Correct.
And
Yes, and this is something where I think we've had this shift of, like, what is the boogeyman, so to speak. So I mean, in the '90s, I remember everything was becoming non-fat, but then in parallel with that, there was basically an increase in these, sugars and highly processed things. And then now it seems like the research is coming back around that maybe the fats weren't so bad, or maybe not quite as bad, and that all of these high sugar things and artificial, highly processed foods that are high in sugar content, that those are not so good for us. But I think some of these things, they are not kind of a la carte. For example, it may be, as I understand it, having, say, full fat yogurt is maybe good for you in a sense, but part of that is that fat and protein in those foods help you to have earlier satiety, that maybe you're not going to eat so much of it. So if you're eating an enormous thing of it, is probably still not great for you. But if you take advantage of the fact that protein and fat help you to feel full and you're consuming less overall, maybe that's where some of the advantages lie. But
yeah,
it's hard to say.
it's a truly a tough situation. But the one thing, I mean, I think we can safely say the low fat movement definitely created or paved the way for this obesity and metabolic disease pandemic we are having, because to replace fats, as you said, the ultra processed food and the corporate companies probably came in with their hyper palatable foods as well, and so much chemicals in their food which is not natural to our intestines to absorb. I think that kind of leads us to a topic you touched earlier, but I want to talk a little bit more, is the gut microbiome.
Mhm.
You talked about prebiotics and how fiber rich food helps with the prebiotic growth and the good gut bacteria. I always am very skeptic about supplements. I'm a supplement skeptic, so the probiotics, do they actually survive our stomach acids and reach the colon enough to make an impact to our colon gut health?
It is a great question, and one that I think the answer is difficult. And the reason is that the umbrella of things that are considered probiotics it's a big tent. So it is everything from eating yogurt off the shelf, non-medicalized, just yogurt, all the way to highly pharmaceuticalized, pills and things like this that are can be very expensive. And the rigor with which these things are studied to know what impact does this really have on your gut health is highly variable. And because these fall under the blanket of supplements, their degree to which they are regulated is much more limited than pharmaceuticals per se. So that's a long way of saying that I think it is difficult to know. We don't know, I don't think, or rather, I think it is fairly safe to say that, and what I say to some of our patients is that if you go down these aisles and you want to buy some, probiotic supplement, probably the only thing at risk of harming is your wallet. That some of them, they are expensive and they may help you, they may not. They are almost definitely not dangerous, though you can't say with 100% certainty, but they are almost certainly safe. But you may be just as well off to have any other type of fermented foods, essentially. So, things like yogurt or kimchi or other type of sauerkraut or something, that these are things that probably offer, or kombucha is another one that comes up a lot. Patients ask that probably those have some degree of benefits to introducing these favorable bacteria to us.
So, I mean, this is where the balance comes in, right? Like in Asian countries and Japan and etc., they eat a lot of these fermented and pickled foods, which has the high levels of nitrites and everything, and that led to the increased levels of stomach cancer.
Yes.
So, even if it is good for you, it does not mean you need to have, kimchi 3 times a day or sauerkraut 4 times a day.
Yeah, this really gets back to the all things in moderation concept, though. As to what is moderation, it's in the eye of the beholder, I suspect.
Yes.
It's very hard to know, but I think probably these are all components of things that are favorable to our gut health and probably to our broader health, as to the extent that they are associated with inflammation and things along those lines. I especially there are a couple places nationally that have been thought leaders in this area. University of Chicago, there are a few really outstanding scientists who studied the role of the gut microbiome in everything from inflammatory bowel disease to leakages when we do surgery and put the bowel back together. That we think these things, that the bacteria living in our gut probably play some role in these issues, and I think hopefully the science is getting there to a point where we can not only make these observations to say, okay, we know that the gut microbiome of someone who's very obese is different than someone who is not, or the microbiome of someone who has Crohn's disease is different than someone who does not. Yet, how do we take these observations and harness them to make improvements, to be able to have actionable targets for therapies or things like that?
Right now, I mean, maybe the answer is somewhere in the future, but right now, is there a role for a fecal transplant in prevention of colon cancer or even in the treatment of colon cancer?
To my understanding, I have not seen it studied in the space of treatment or prevention of colorectal cancer. I have seen it used, and probably the place where it has gained some traction is in the treatment of something called Clostridium difficile colitis, or C. diff colitis. This is C. diff. These are a particularly nasty bacteria that can gain a foothold in our large intestine and cause quite severe illness. And one of the ways we can combat that is by giving a leg up to the good bacteria, and fecal transplant is one strategy to do that. Clearly, there have been some challenges of how to practically do that, and I don't know if your audience are about to eat, so I don't know if I'll go too much in detail of that,
Sure.
but it has been everything from what you might think it is of basically, putting a bowel movement in a blender and giving it as an enema or something, versus some other more kind of sophisticated ways of trying to better understand how do we get these good bacteria to flourish in someone's GI tract via other means. So I think there'll be more to come on that. And I do think that manipulation of the gut microbiome is on the horizon of a way that we can probably manage a number of gastrointestinal conditions, but probably not where we are just yet.
Okay. I mean, I think that's a fair description of the current state of affairs. We talked about prebiotics and probiotics as a supplement. Another big supplement which gets thrown around in the colon cancer world is a vitamin D supplementation, and how deficiency of vitamin D can cause colorectal cancer. What is the status on that?
Yeah, so I think there are a number of associations that we observe, and vitamin D is among them. And I think there are some that it's kind of a no-brainer to say it does so many other good things for you in terms of your bone strength and just sort of your general metabolic function, that being replete with vitamin D is a good idea. And this is something that this can range from anything of drinking or sort of eating foods that are rich in calcium and vitamin D, like dairy products, for example, and then of course spending time outside to get the sun exposure that facilitates the metabolism of vitamin D. But I think it is probably not at a point where so many of these things, we think that they probably make a little bit of difference on the margin, but probably not something that people need to be going out of their way to be doing things at say supraphysiologic levels of taking these things to excess, because we think that having just the right amount is probably the right idea.
So, at least in the cardiology space, I think we've gone through different diets, and finally we have honed in on Mediterranean type diet is probably the best. I mean, and even then, reduce the pasta, reduce the alcohol, but the green leafy vegetables, nuts, olive oils, good fats, that's what we have kind of. Is there some kind of a specific diet for which is good for the colon per se?
It is funny how there's been this convergence around the Mediterranean diet, because it has come up in a number of contexts related to gut health as well, in addition to cardiovascular health. And I think the principles of it, of being fairly high in fiber, high in good fats, proteins, having, I can't recall where I saw this, but having a whole rainbow on your plate, green leafy vegetables and different, colors of foods, that these are things that reflect their nutritional content, and having that diversity of diet. And so, for example, the Mediterranean diet is being actively studied to treat or prevent something called diverticulitis, another inflammatory condition of the large intestine. And it appears to have some the early studies seem to show some success in that from a preventative standpoint. So I think it's something that we're likely building a fairly broad consensus that this type of diet is healthy for us in a number of ways.
Yes, we talked about the diet. We never talked about exercise. Yes, exercising improves the overall health of the person, etc. But has there been any particular or any specific benefits to the colon cancer spectrum?
Right. So I think from that point of view, we know that at least to the extent that exercise is associated with kind of reduction in obesity. So we know that obesity has some implication with colorectal cancer. So to the extent that it's a part of that kind of broader healthy lifestyle, it's also difficult in many ways to study this as well, because so many things travel together. So people that exercise tend to be the people that eat very healthy, that, they tend to be the people who are not smoking. So it almost ends up being this bundle of interventions that come together, and it's hard to tease out which of those is really maybe doing the heavy lifting of, or maybe it truly is all of them contributing to the positive health effects.
Absolutely. And I mean, I think no podcast is complete without talking about AI in
Yes.
healthcare and medicine. So
Yeah.
let me ask the customary question. How do you think artificial intelligence is going to change the way you, in colon cancer or in colorectal disease itself?
Yeah, so I think there are at least two and likely many more areas in which artificial intelligence and machine learning are already helping. So the first of those is in the realm of colonoscopy. So just very briefly, the way colonoscopy works, we put a camera on a long tube into your lower GI tract, and as we're there, we look at all the surfaces and see, are there any growths that could be concerning for being precancerous or cancerous. Already now we have AI assisted colonoscopy where the in real time the machine will highlight or put an arrow or a box around an area that they want to call your attention to. That these algorithms have been trained on many thousands of hours of colonoscopy, of knowing what does a polyp look like, what does a cancer look like, and they are something that can augment the treatment. As to whether these are making a tangible difference in improving say rates of polyp detection and things, I think the jury is still out on that. But this is something that we are even it has been adopted already today in many centers. The other one is in the area of analysis of genetic material. So at our institution, for example, local people in South Carolina may have seen billboards or advertisements for In Our DNA SC. So this is a effort to obtain genetic material across a broad population within South Carolina to look for genetic predispositions to cardiovascular illness or certain types of GI conditions. And the wealth of data that is generated by that initiative really lends itself to study with machine learning and artificial intelligence to look for trends and patterns and things. So I suspect that is on the very near term horizon.
That's fabulous. I'm looking forward to it. I did send my saliva for the testing. We're coming kind of towards the end of this discussion, but if you have to give, top 5 pieces of advice to an average person, coming across this podcast and is wondering, what are the top things I should be doing on a day-to-day basis to keep my gut healthy? What would those 5 things be?
Yes. So the first one is for people that are experiencing any kind of concerning symptoms. If you're seeing blood with your bowel movements, if you're having weight loss, that you're not trying to lose weight, but you're losing weight, you have a big change in your bowel pattern, this is something that you should absolutely get checked out by your primary care doctor, and they can steer you in the right direction as to where to get checked out, whether you need additional testing. And this is even for people who are in their 20s, 30s, 40s, and of course older than that, because we are seeing some of colorectal cancer earlier and earlier. So if you're having symptoms, don't put it off, get it checked out, and bring that to the attention of your doctor. The second, for people that are of risk to initiate screening for colon and rectal cancer, don't delay. See your primary care doctor. Make an effort to get tested. Catching this disease early is the number one thing to either prevent it or have a good outcome if it does affect you. The third one is probably more global of all things in moderation, but get lots of fiber in your diet. Those are, and kind of for the other things, whether it's red meats or alcohol or coffee or what have you, try to enjoy those things in moderation. Those are probably the top three. I think the other ones would probably be extensions of that, of, go out and get some exercise and things, but those are really the big ones.
Absolutely. Tommy, thank you so much. I truly appreciate you taking time and, talking about everything, the screening and the prevention strategies and what to look for in the future too. I truly appreciate you taking time.
This was so fun. Thank you so much for having me.
Thank you so much for listening. If you found us valuable, you can subscribe to the show on Apple Podcasts, Spotify, or any of your favorite podcast app. And also, please consider leaving us a rating or a review, as that helps others find the podcast too. I hope you have a great week ahead.